in order to understand our point of care deployment, it's important to understand our categories. And our categories are derived from the definitions that we described previously. So we have 5 broad categories, all of them pertaining to actionable findings. And our first category, our category 1, point of care deployment, is involving AI algorithms that are actionable, non-incidental. So that imaging study was ordered for that indication, but the finding is critical. So think intracranial hemorrhage on a CT of the brain, or think pulmonary embolism, but on a pulmonary angiogram study, right? So these are critical findings and they were expected. So that we consider to be our category 1. For those, we in the outpatient world, we will have a nurse practitioner holding the patient, contacting the referring clinician once the human validates that AI finding, right? So if the AI detects it before the patient leaves the department, the nurse practitioner will hold the patient, validate that finding, and our clinical coordinating team will contact the referring physician with that critical finding in the outpatient world. In the inpatient world, we don't require that because the patient's already being monitored in the hospital. So our job is just to convey those results pretty quickly. So that's our category 1. Our category 2s are a little bit trickier. So those are actionable, critical findings, but they were incidentally detected. So that for you would be your incidental pulmonary embolism. So detecting pulmonary embolism on non-gated studies. So no one was expected to get this. A CT of the chest may have been done for pneumonia or a pulmonary nodule, and all of a sudden you have the result of a critical finding. That's really important because we have a very large oncologic population that we serve, and we had a very high number of pulmonary embolisms that were incidentally detected. So we had to build a workflow around that. And our workflow, our point of care, category 2, had us holding the patients at the imaging center, having a nurse practitioner monitor and stabilize the patient, contact our clinical coordinators once the human radiologist validates the finding, then conveying that finding to the clinician and determining disposition. If the clinician is not available to receive the disposition, the patient is sent to the emergency room. And we've ran pilots through this, and this is the exciting part. For the incidental pulmonary embolism category 2s, we've run pilots where we're actually showing that the nurse practitioner involvement is resulting in a faster treatment time and by extension, a decrease in mortality. So that human intervention, comparing that workflow where the nurse practitioner is involved in the care of the patient and not just the radiologist monitoring the widget, we're finding that that added human intervention has a significantly positive impact on the patient's outcome. Our category 3s are a little bit different. So our category 3s are actionable, non-incidental, so expected, but non-critical findings. So examples of those would be, for example, brain aneurysms in CTA studies, right? So it's not critical, it is not incidental, right? So people were expecting, that's why they ordered the scan. So those, we really don't have to hold the patients in our department, right? We can, since they're not critical, we can allow the patients to leave, and we can follow the classic path of reporting the results through our traditional pathways once the radiologist has read it. Our category 4s are trickier, and that's what we're facing now. Those are the ones that we're hoping to deploy in the near future. And those have to do with, for example, incidental coronary artery calcification. So these are actionable incidental findings that are not critical. So not critical, they're actionable, and they're incidental. So it's not a critical finding like a pulmonary embolism or a brain bleed, but it's still something that is that has to be followed. And those are our incidental coronary calcium scores that we're detecting through one of the your algorithms. And so for those, what is the nuance of that category 4? Well, it kind of falls into the realm of predictive medicine. So you had a CT of the chest for whatever reason, and all of a sudden now AI is extrapolating a significant finding that may not be critical, but something that we need to do something about. So for those, we have to have a level of involvement, meaning because no one was expecting this result, it's not fair to the patient just to wait for the follow-up. That follow-up with the clinician may happen weeks after because no one was expecting anything significant. And in the interim, no one was expecting to digest this information. So our point of care category 4s also involves the nurse practitioners, but in this case, it's done after the patient leaves the department. where the nurse practitioner or an advanced provider will contact the patient and said, hey, Mrs. Smith, that CT of the chest that you had for pneumonia, it turns out that you have a high calcium score, and that's what this means. And would you like to follow up with cardiology? Do you have any questions about this? And that way we can close the loop with the patient so they're not shocked when they get these results. And then lastly, the category 5 would be algorithms that are not FDA cleared. Obviously, that requires a much bigger infrastructure build, a lot more supervision and governance. And so currently we're not deploying non-FDA cleared algorithms at UHealth.